It is a huge honor today to be interviewing David Eshom, who's down there in San Diego, and I'm a big fan of yours. You got 30 posts on Dental Town, and you're huge into cosmetic dentistry, and you on Invisalign and all things like that. And first of all, I want to just thank you for spending an hour with me today.
Happy to do it, and I appreciate you asking, Howard. I love Dental Town. I know 30 posts isn't a whole lot, but I do listen and lurk and learn by going through the posts. So what you've done for dentists and dentistry is there's nobody that matched it.
Oh, thank you. I got to ask you, of all the, there's 9 specialties in dentistry, 7 are clinical, 2 non-clinical, public health and oral radiology. A lot of people, you know, you're accredited in the AAC, the American Academy of Cosmetic Dentistry.
Correct.
A lot of dentists, they're afraid of those kind of cases. I mean, in all seriousness, there's a couple of patients that, you know, some patients we like a toothache who just is begging you to fix it. Some patients we don't care so much for, like a screaming 3-year-old who needs a root canal, and you're like, give that to a pediatric dentist. Or a TMJ patients, because a lot of times those are just really high anxiety. A lot of times those are just crazy people. But man, nothing's more stressful when a beautiful woman walks in your office and sits down with photos of what she looked like on prom night 30 years ago and pictures of gorgeous supermodels, and they want you to do that. I don't want to do that case. What attracted you to want to do those types of cases? Are you a glutton for punishment? Or are you just
Well, that wasn't the first thing I thought about when I wanted to approach those cases. The first thing I thought about was, you know, helping somebody feel better about themselves. And as I found out, you know, you're not incorrect. You are correct. 80 to 90% of the patients are just fine, but the 10% that are overly picky can really make you crazy. And so the way I went into it was trying to help people and doing it in an artistic way. And I'm very thankful for what I do, but I do have to deal with some of the people that are very, very nitpicky.
So where along your journey, was that the first big game changer in your journey in dentistry from graduating from dental school in 1985, you're practicing along with, was joining the AACD your first game changer, or were there bigger, equally more important decisions you made before you made that decision?
No, that decision kind of opened the door to what was my pursuit of quality dentistry. And really that's kind of what I'm all about, is providing quality dentistry in a comfortable atmosphere in a very communicative way. And so the AACD taught me how to do quality dentistry and scrutinize myself, and then kind of just stand there in front of people, you know, with no clothes on and let them critique me. And then that what made my dentistry better. And the more I listened to people and the more I could take, you know, criticism, the better I got. And so I feel like that was my game changer, to seek out quality dentistry. From there, I needed to be able to communicate what quality dentistry is to my patients so that they can accept quality dentistry. And then once they accept quality dentistry, they need to understand that it's going to cost more. And so I need to communicate the value of quality dentistry for them and for their lifetime. So that's where the journey started at AACD.
So your journey was first to be a quality dentist.
Correct.
And then AACD just helped you become more of a quality dentistry, period.
Correct. By opening my eyes and letting me see the things that make things, that change things from average to superb.
So my job on these, David, is, you know, the whole mission with Dental Town is in 1998, I just was professionally isolated and lonely. I just want to be able to talk to a guy like you. So now my job on a podcast interview is I'm trying to guesstimate what 4,000 individual listeners in their car on their commute to work, they're standing on a treadmill, they're doing laundry. I'm trying to guesstimate their questions. So I'm just going to go with, what is the AACD? I've never heard of it. What is this? I mean, obviously I've heard of it, but what would you tell someone who's never heard of the AACD, or they just got out of school last year? What is the AACD, and what are they all about?
Well, the AACD is the American Academy of Cosmetic Dentistry. It's the largest cosmetic association in the world, and it promotes high quality cosmetic dentistry to its members. And we have an annual meeting to which I just attended last week in San Francisco, where there's about 2,000 like-minded people interested in providing high-quality cosmetic dentistry to their patients and learning how to do that better in a more minimally invasive way. And so that's what they're all about. And you can be a member, or you can seek credentials. And in my case, the first credential you seek is accreditation. And in that case, you provide 5 different type cases: a bonding case, a direct veneer bonding case, veneer case, a single anterior unit case, and a bridge or implant case to the examiners or your peers. And if you treat that case in a quality manner in which they give you criteria for you to check yourself, you get the accredited credential.
Is the accredited the fellowship, the FAACD?
The next level?
Oh, that's the next level. So first, you want to be an accredited member. And how long of a journey would that be for your average AACD member?
Well, I took the longer journey. It took me 5 years. Some people can do it in 2 or 3. Some people might take 7, but I was one of the longer groups.
When you're accredited, do you get any special initials or anything, or not really?
Yeah, you get AACD instead of FAACD.
Okay, so instead of a fellow of the Academy of is it a fellow of the American Academy of Cosmetic Dentistry?
Right.
You'd be an accredited.
From the American Academy of Cosmetic Dentistry.
Okay, and then the next leg up the stool would be fellowship in the AACD?
Okay, yeah, that's for the real crazy individuals, because you not only have to submit your 5 cases, but you have to submit 45 more of those, to which they put your teeth up on this huge screen in a dark room and look at your teeth, look at your layering, look at your prep, look at the tissue, look at the angles, look at the contour, look at the color, all of that very, very scrutinized, and make sure that it meets the accreditation quality, and you do that 45 times. And so the fellows are quite well trained and very very
So you present all 45 of those at one session, or do you just keep submitting them over the years until they equal 45?
You put them all together and then you submit them all at once. So yes, you'll submit them. You're not there in person now. They do an oral interview at the end, but you submit your case digitally. When I submitted them on slides. That was really difficult. But now they submit them digitally, and then the examiners look at them, and then they'll do an oral exam at the end of that.
And the AACD was started in Wisconsin, right, by Jack?
Yeah, Jack, and also a dentist in San Francisco. I'm forgetting his name now, too. But the two of them co-founded the AACD.
Yeah, what was Jack's name? I'm so...
his son lectures, and he's lectured for you on your Dental Town conventions, too.
Yeah.
He's in Madison there also.
Yeah, an amazing man. John Kanka was also an early president of the AACD. I think he was like the 3rd president of the AACD. And the new president is my buddy up the street, Joyce Bassett.
Joyce Bassett just got installed last week.
Yeah, amazing group. So I want to ask you, I'm trying to estimate these guys listening to the podcast, and I know that right now there's probably 1,000 dentists right now saying, oh, come on, David, you're in San Diego. That's Hollywood movie stars. I'm in Salina, Kansas. I mean, come on, dude, I'm in Fargo, North Dakota. Would the AACD, getting a fellowship in the AACD, would that apply to half of America who lives in rural, small town, farm America? Or middle markets of 100,000 versus obviously San Diego or Beverly Hills or something like that?
I would say to those dentists is that you just have to ask themselves what they're interested in. For me, you're not going to get good at something you're not passionate about. For me, I was passionate about learning how to do artistic cosmetic dentistry, so I went, and I didn't go to be accredited. I went to learn, and as you start going to the classes and seeing things, you want to try that. And as you try that, it either turns you on or it doesn't turn you on. You think it's too hard, and then maybe you don't become accredited. But, go to the meeting, see what it's like. If you want to be better at cosmetic dentistry, you don't have to do veneers. Just being better at bonding. Just be better at taking care of your patients when they need a single unit crown in the front part of their mouth. if you just want to go to the AACD meeting, and you will see the best, and you'll see people that are nice. You'll see people that are like-minded. They'll talk to you. They'll share their problems and their good things, and you'll learn from them. And that's what happened to me. And I like the people, and I like the learning environment, and I like the subject. So that's why I got passionate about it, and that's why I went to the effort of being accredited.
Okay, so you got out of school in '85. I got out of school in '87. So the first 10 years out of school, the thing that just makes your stomach just like a woman comes in, she broke 8 and 9 is fine, and you got to do a single crown on 8. Walk her through that. What's the low hanging fruit? What can this lady listen to a podcast today learn about when they come to you and you got to crown 8 and 9 was made naturally, and you got to make 8, and you're just a talking monkey? What would you recommend? What procedures, processes, and materials? How would you treat that, or would you just refer it?
No, that's right up my alley. And after going to the AACD and become accredited, you should be able to handle it in both a clinical and a patient management standpoint. The main thing I would do is I would show her cases of single front tooth that I've done. And as long as they're not one of the people you were talking about at the beginning of your broadcast where they're ultra crazy, if they liked what I did with 2 or 3 other people with a single front crown, then I know that's somebody I can treat, because that has a little red flag on it. If somebody's ultra picky, they'll always be able to see something about it.
I got to stop you right there, because you just said something so profound, and a lot of the kids might not have caught it. Is when you go to a doctor and they show you pictures of their own work, that is an instant confidence builder. That's how you can get away with charging more, not taking PPOs or whatever. That's so I cannot tell you how many times I've heard a woman talking where it was, eyelid surgery or a boob job or something, and they went to 3 or 4 different doctors and they were showing them brochures. But then this doctor started showing them cases of their own work, and that's where they stopped and got it done. That is so important to photo document, isn't it?
It is, and but again, what you're talking about is someone who, if they like your work, that's somebody you can work with. But if they're nitpicking the work that you've done that you think is some of your best work, then maybe that's somebody you don't deal with. So, but again, that's 5% of the people, maybe 10% of the people. So if you want me to walk you through it, that's kind of how I do it. And then I also tell them, I need to see what it looks like underneath the tooth. Is it dark or whatever? I guess it's broken, so I can see that. So we talk about how dark it is. And then we let them know that the first time I put it in, probably we're not going to seed it. But in the meantime, I'm going to make them a nice, perfectly contoured temporary that they'll be happy with if we have to go back and forth for the shade at least once and maybe even twice. That's how I would tell somebody new that wanted to do a single unit front crown as to how to do it, along with how to manage the patient's expectations, because that's going to be the big problem, not so much doing the clinical work.
And I still think managing that patient expectations is these doctors listening, they need to start photo documenting some cases, because that's a big part of patient communication and patient trust. Is when you open it. What do you have? Do you use a photo album or these slide presentations on your computer or an iPod? What are you using, David?
Well, in my ops, I have monitors, and there's 2 monitors. And so with each patient that comes into our office, we do a new patient exam with, which I would recommend for new doctors to think about the exact steps in their new patient exam. One of those new steps should be to take actually extraoral photos of the patient, along with the intraoral camera photos of the patient. So the patient gets a tour of their mouth. They get to see what you see. And to be honest with you, most patients are going to be pickier about their teeth than you probably will with their teeth. And so it's a whole communication education environment when you take the pictures. And so someone actually learns something new about themselves. Somebody could be 40 years old and they're going to learn something new about themselves by you showing them extraoral pictures of themselves. And that is something that really makes them bond with you and really makes them listen to you.
Well, David, you just opened up a whole can of worms, because probably the biggest controversy in practice management is the patients are calling, they just want a cleaning. Do you do a new patient cleaning or do you do a new patient exam? What do you do?
My practice, Howard, to give you a little bit about it, is all fee for service. We take no PPOs, we don't take Delta. We have patients pay in advance and then they get the insurance from them. And I don't mean that as a brag. I mean that just as that's what I've worked towards, and that's how I feel I can best treat patients. So a new patient calls and they just want a cleaning. My staff recommends that we do a cleaning exam, but if they want just a cleaning, I'm okay with that. They'll come in for the cleaning. I have total trust in my hygienist. I'll go over there and say hi and do a quick visual exam. But if that's what they want, that's okay, because they want to get to know us, if that's the case. Once they get to know us, once they see our hygienist, once they see our office, once they see me say hi, then at that point, we can schedule them for an exam, but they're not going to come in and get a second of cleaning unless they've had that exam. So that's how I handle it in my office.
And just to set realizations for these kids out of school, how many years did it take you to be able to go Delta insurance free and PPO free and have practice? I mean, did you start out that way day one, or how long along your journey did that take?
Let's see. I can tell you the year. It was 10 years, 12 years ago. So what is that? 2002? So I was into practice 15 years.
85 to 2002?
Two, mm-hmm.
Okay.
Yeah, 15, 16 years. I was in the AACD at that time. I had taken Frank Spears' hotel classes and all his workshops. I had consulting with Jim Pride. I had consulting with Bill Blatchford. And after my consulting with Bill Blatchford, he's the one that gave me the courage to try it. And I did it, and I lost half of my Delta patients. UCSD, the University of California, San Diego, across the street, all Delta. But I survived. And what I started doing is just exactly what we just started talking about, is I started taking pictures of patients and taking my time during my new patient exams and showing them their pictures and talking to them about their teeth. But the first thing we talk about is how healthy are their teeth. But after health, we start talking about appearance and whether that's something for them or not for them. If it isn't for them, then we're happy they're healthy. If it is for them, we talk about the different options for it. But when you have their teeth up on the screen and you're talking to them, that's the best way to find out if that's something they're interested in. And I don't want to push anything on anybody. So if they're interested in it, we talk about it. But yes, it was a long time before I went Delta. And I'm not sure how and if someone could do that nowadays. That's one of the questions I wanted to ask you, Howard. What do you think of private practice and where practice is going? You have your MBA. You've seen the business scene. You scour it. You know about it. I think somebody can, but it's not an easy thing. And I'm glad I don't have to do it again.
Well, you asked me a question, so I'll answer it. I think that I think that half of America buys on price, and I think half of America buys on relationship. And I think that a lot of people that buy on relationship aren't necessarily just the rich people. I think there's a lot of rich people who just buy on price, and there's a lot of poor people who buy on relationships. I keep seeing analogies thrown around that dentistry is going the way of Walgreens. When I go to other countries, a lot of their prescriptions have gone the way of ATM machines. The doctor gives you a prescription on a smart card. You stick an ATM machine, a bottle comes down, the pills fall out of a hopper, throws a label on it. So a pharmacist is selling a product. A dentist is selling surgery in an operatory, hands-on. I got to meet this doctor. I think dentistry will always be very powerful. As far as the corporate dentistry going along, I see, when I first got out of school, Orthodontic Centers of America had $1 billion market cap on the New York Stock Exchange with Lazarus out of New Orleans, and that spectacularly imploded. And a big part of that was they weren't keeping the doctors. Every time they bought an orthodontist practice, as soon as that orthodontist could go, they ran. And I keep telling dentists, and there were another dozen on the NASDAQ, and every one of them is gone. And I keep telling doctors that if your business is selling dentistry, the thing I'd look at is, do they keep their doctors? And when Orthodontic Centers of America couldn't keep their orthodontists, and today there's a lot of these corporate dentistry chains, their average length of time a dentist stays in the clinic is 1 year. So what shows the other problem? When these kids are coming, so the reason we see so much corporate dentistry is they provide two services. Guys like me can't sell my today's dental practice to a kid that just walked out of school, but I could sell it to a big corporate America in an hour. So it's a liquidity play. So they're there because they got access to huge amounts of money. And guys like me, we have liquidity. If I dropped dead of a heart attack and my family wanted to sell my practice, Heartland could write a check in an hour. Okay. The kids coming out of school, they, with so much student loan debt, they're having a harder time getting access to capital, and they just want a job. It's a residency. It's the new day, Army, Navy. In our generation, if you said, well, I'm going to go do 4 years in the Navy to get some experience, they'd say, well, that's good. Today, if you say, I'm going to go do 4 years in corporate dentistry, a lot of people are judgmental about that, but they have a place. They're not going away. I don't think they're going to, I don't think they're nearly significant, but the thing that is significant is that you have an incredible personality, you have incredible confidence, and you have a repertoire of good clinical skills that you're good at. And if you don't have a personality and you don't have a warm and caring staff, and you're not good at doing, whether it's cosmetic dentistry, root canals, placing implant, if you're not good at anything, then yeah, you're a commodity, and you're in trouble.
Correct.
But I'm going to go back to you. So you got out of 1985. You dropped Delta in 2002.
Correct.
Okay. When did you join the AACD? What year was that?
In 98.
98. And then you
Correct.
credited Bill Blatchford. What year did you join Blatchford?
Blatchford we did in about 2000.
2000.
Did a year and a half with Bill Blatchford, yes.
And Bill's the one who talked you into just going for it, dropping Delta and going for it.
Well, you have to hear things a few times and then they finally click. I heard it with Frank Spear. I heard it with Jim Pride. I heard it with AACD. And then after I heard it with Bill Blatchford, that was the time I said, hey, I feel like I can do this. I want to give people the best that I can. And if people want the best I can, I have to charge more. I didn't feel comfortable charging somebody that didn't have Delta, $1,000, and then charging somebody who had Delta $800. That's not fair. They're the same people, they need the same procedure, but you have to charge them 2 different fees. To me, that doesn't seem fair. And then plus, I couldn't take the right amount of time and use the right quality lab with somebody that's paying me $800 instead of $1,200. So it was kind of a rub ethically. And so you have to decide what game you're going to play. Are you going to play the price game, or are you going to play the quality game? And at that time, Bill Blatchford was talking to me about it. And with the help of my wife, I want to tell you all along, my wife's been in the front part of my practice, making sure things are customer service oriented. So you don't just do this blind. You're prepared, and your whole office is prepared. And then when I did it, after hearing it from Blatchford, then I was very, very pleased after being very, very scared for 6 or 9 months.
Well, you opened up 2 can of worms, so I'm going to address them both. First is the wife one. So your wife is your front office, your front desk, your...
No longer.
But she was?
I'm still married. She was for 13 years.
What year is that? What year?
So let's see. We bought the practice in '88 until 2001.
And so what was it like having your wife work the front desk? You're still married to her?
I still am. 32.
Looking back,
years
was that a good move, or was that a stressful move? Would you do that again?
Of course I would. And if you can work with your wife, I would highly recommend it, especially if she has a caring attitude and wants the same type of practice you do. Because, my wife worked at Nordstrom, was a manager with Nordstrom. We decided to move from LA to San Diego. She gave up her job. We bought a practice. And I want to tell you the whole story, if I could, is that I bought a practice and I was young and dumb, and I saw the doctor was seeing a lot of new patients, and he was at capitation, and he was in San Diego, and it was just nice practice. And so I just walked into it, paid a top dollar, and then found out that the reason why he was seeing so many patients was he was doing $29 cleanings, x-rays, and exam. And so that's how he got 40 or 50 new patients a month. And so I had to transition out of that $29 cleaning practice into a regular practice when I'm not doing that, taking PPO insurance, and then transition out of that into fee for service. And so I'm proud of what we did, but along the way, my wife was providing guidance in the front, customer service in the front, the Nordstrom attitude in the front, so that I can concentrate on my clinical skills. I told you all the clinical skills that I was going to every year, and then let her run the practice. So without my wife, I wouldn't be where I am now.
And what does she do now?
Now she stays at home, monitors the practice on the computer from home, does the payables, does payroll, and then gets on me when things aren't going right.
Right on. And
Yeah.
how long you guys been married?
32 years.
Oh, that's amazing. That's awesome. And I
But
want
we have a funny story real quick here, Howard. When we decided to work together, my wife would talk to me on the way home in the car. And we lived in Lagoon, up in Orange County, and drive to San Diego for almost a year. And so I would hear all about the practice all the way home. And so we made a rule that as soon as the car drove in the driveway, we can't talk about the practice anymore. And so that was one of the rules. The other rule to practice with your wife is we drew a line between the back office and the front office, and she handles everything in the front. I handle everything in the back. I don't get in her way. She doesn't get in my way, and that's how we are able to still be married.
And how many children do you have?
2 kids, 17 and 18. And again, we were 13 years like that, and all the people in our office were having babies, and we go, oh, well, after so and so's baby, we'll get pregnant. Well, I got to 13 years, and I was turning 40. Sorry, we couldn't wait anymore. So
They're how old? 17 and what?
17 and 18. One's going to college this year, and one's going to college next year.
Oh, right on. So we see these debates on Dental Town. Is it safe to say that CAD CAM is better for an all-purpose, single unit crown in the back, but not for a high intense cosmetic case in the front?
That's my opinion. I know other people may debate that, and that's what Dental Town's all about. But
it's just you and me. This isn't the general debate.
I know. I don't think you can do a CAD CAM crown in the front unless the tooth is very dull and very monochromatic that you're matching.
Or if
unless you know how to cut it back and layer it.
Yeah, and it's one thing, and then also in the back, like you're never going to find a prosthodontist who said, well, I'm going to mill out 7, 8, 9, 10 crowns in an arch. I mean, most all your prosthodontists say, well, if this is multiple units, I would never do that in office. I would take an impression and send it out. I mean, wouldn't you agree with that?
I sure would. I haven't had much luck with CAD CAM, so I'm on the other end of the fence in terms of one-day crowns and milling out things in your office. So
to be clear, what percent of the AACD accredited members would not use CAD CAM for anterior work?
I'd say 95% of them.
Okay, and what percent would not? And what percent would not use CAD CAM for posterior work?
That survey, I couldn't really tell you, and I just know kind of the anterior work because that's what we see from time to time. As I served on the board of directors and served on the professional education committees. So posteriorly, I couldn't really tell you. I know it's coming up and coming, but I'm not seeing it prevalently.
Okay, and when you and can we be more specific on that anterior crown? Let's just say it's a 30-year-old woman. She fell down. It was trauma. She broke off number 8. It's not black from having a root canal when she was a kid. There was no metal parapost in there, degrading and all that. Just a standard clean. She's a 30-year-old woman. She's good looking. She's got a high lip line, and she busted off, probably, a huge class 4 fracture. You're not going to do direct bonding. You're going to do a crown. What type of crown would you do on that? Talk through the details. What would you impress with? Would that be an optical scan? Would that be polyether? Are you a polyvinyl guy? What kind of crown would you? Yeah, would you do an Emax crown? Would you do stacked porcelain?
Well, my lab, we're going to do a polyvinyl siloxane impression. We're going to take a picture of the core of the tooth or the stump. We're going to prep just below the margin without damaging tissue.
Would you pack cord before you did the margin work so you wouldn't nick the gum? Or would you prep a subgingival margin with the tissue it is?
And no, I place cord and then go about a 0.5 millimeter subgingival.
And do you just place one cord or do you place 2 cords?
Depends on the case, but most of the time I just place one cord.
And would that be a 0, a 1 cord?
It's a double 0.
It's a double 0.
Actually double 0.
And who makes it?
Ultradent.
And you do that because it's going to push the gum tissue down and out, so you have a less chance of nicking the tissue?
Correct. And then the margin's going to be either at or below the gum line. And being that there's going to be a translucent facial portion of that crown, it's not going to show. It's going to blend in with her tooth just like it would a veneer.
And is that, and what type of prep would that be? Would that be a shoulder, a heavy chamfer? What kind of?
It's a heavy chamfer.
A heavy chamfer.
Correct. And then my lab currently uses Emax and then cuts it back. From time to time, we have to do zirconia and then layer it on top, depending on what the other tooth looks like. And again, I don't expect it to be the exact match the first time.
Okay, but a lot of listeners don't even know what you just said. So you're going to send to a lab, but these guys are alone. So would you mind sharing what lab you're going to send it to?
I sent it to a lab called Hop Lab up in Brea, California, in Orange County.
Hop, H-O-P?
H-A-U-P-T, John Hopt, and his sons work there, and they both, John is a fellowed by the American Academy of Cosmetic Dentistry, and his son is accredited. So they're accredited lab members, and there's accredited dentists.
What's their www?
It's probably www.hoptlab.com.
H-A-U-P-T. Lab.com. Yeah. You should call him and have him do a podcast explaining your exact technique. So you're saying he would start with a Emax crown, and then you talked about cutting it back. Go explain that in a little more detail.
Well, at least at the incisal, there's translucency. There's some characteristics that you need to match in the other central incisor. And so you want to cut it back to the point where you see the incisal of the other tooth, and then you layer clear and colored porcelain underneath that, and then you put a glazed porcelain over the top of that. So when it's baked, the translucency, or how you see through the edge of that tooth, matches the other one. And then in the body of the tooth, there's going to be certain colors that go from brighter to darker towards the gum line. And you're going to want to cut back in there to match that transition, because your Emax is all one color. And you want there to be a gradation of color from the middle of the tooth towards the gingiva. And so sending pictures, multiple pictures, and sending core shades, and then sending a impression of your temporary is very important to the lab, so they can match what you want them to match.
Okay, when I talk to big labs, they say 99% of lab scripts just come in and say tooth number 13, A35. I mean, that's all they get. What does your lab script look like? Is it just tooth number and one shade? You're sending photos. You're taking a stump shade, which means you're taking a shade of the prep tooth.
Correct.
And what percent of dentists do that? Probably 0.001?
I don't know. You would know more than that than I, but most of the people that I
You want to hear something frightening? When I go into removable labs, this just makes me just like, wow. When you go into removable labs, 95% of all the impressions that come in for a cast partial, the doctor didn't even cut a single receipt. I mean, not only is there no design, there's not even, it's like, dude, you couldn't take a football and make you couldn't do anything.
You didn't even need to numb to do that, did you?
I mean, it's just like, you've got to be kidding me. I mean, God, if you can't cut a receipt on a partial, I mean, at what point do you just throw in the towel? So exactly. Explain your lab script. So you would take a photo. Now, these dentists want specifics. What camera do you use to take a photo? I mean, is this on your iPhone?
Yeah, exactly. No, and again, I don't like things to be overly complicated. And so I don't use a through the lens camera. I use I know you like to know companies, photomed.net. They have a camera there. It's called a G16. It has a diffuser on it that nobody else has. So you can hold this camera in one hand, focus it, and take a shot, and they look almost as good as you would through the lens camera.
But
if your camera's not easy to use, you won't use it. So this is an easy to camera.
But wouldn't you say PhotoMed's pretty popular among FAACD guys?
Oh, for sure. For sure. But most dentists, don't want to get up and go that through the lens thing for all these shots. This G16 takes all my shots for me with one hand, and I just set it off to the side.
And how many of your AACD buddies that have their fellowship, accredited fellowship, use the PhotoMed G16?
They probably don't, but I don't know. I do, and you see my results. So I think they should really look at that, especially for their everyday cases. Now, when you submit to AACD, you got to take it through the lens. I'm not saying you're sending these in for AACD,
Now
but I'm sending them into the lab this way.
So how does the photo med picture, you emailing that photo digital, or is this, is it like a, how does the lab man get the photo?
The photos go on to my computer via a iFi card, which is a Wi-Fi
So
card.
it's a digital photo.
Correct. And then it goes on my email with my instructions, along with the lab slip, along with the case with all the impressions and temporaries and all that kind of thing.
So you're emailing the photo and the lab script and then mailing
Correct.
a polyvinyl Sluxen impression.
Correct, with a written lab slip there also.
Interesting. And what PVS are you using?
Have to turn around. It's this Simpress material.
Simpress.
Yeah, I have a machine that.
Yeah, I see the machine. It looks like I use when I use the brush, I use Emperor gum, same machine.
Yeah.
But it's
yeah.
it's Simpress.
Well, that's the machine. Let me take these headphones off. Sorry, it's Exojet from GC.
Exojet from GC, and GC's General Chemicals out of Japan, Tokyo, right?
Correct.
Yeah, and the reason to my podcast is a lot of times when people are asking me like, why, don't be anal, it's a PVS. I always get that on, these dentists are alone, and he's alone, and he's listening to you, and he doesn't want to hear, oh, I use a composite. He's like, well, dude, what composite? There's 50 different types of composite. So they always want to know specific because they're all alone, and they want to hear what you're using, not what some rep walks in their office and says, oh, use this, because they don't know if that's because,
No problem. No problem.
Okay. So then I want to take you through another case. Just your bread and butter first molar crown. The most likely tooth to get a crown is a first molar. Most likely tooth to be missing is a first molar. Most likely tooth to get an implant's a first molar. What is your bread and butter first molar crown on just an average patient? It doesn't have to be a hot woman. It could be a 52-year-old short, fat, bald guy like me. If I came into you and my molar broke in half, what would be your bread and butter crown? Would it still be EMAX? Would it be just like everything you said for number 8, but it'd be a first molar?
Exactly not.
Exactly not.
Exactly not. The first thing I do, Howard, is I try to do minimally invasive dentistry. So I don't do a lot of crowns. I do a lot of onlays. And so I'm going to do a onlay on a tooth whenever I can, if I feel like it's going to be strong long term. That's going to save the patient, tooth structure and the possibility of future root canals. And so the first thing I would do is I'd analyze it to see what strength it had and whether I can do an onlay. And if I could do an onlay, I use a diamond onlay from Rocco Lab in Escondido. It's a blend of a composite and porcelain. It's not an all porcelain onlay. It bonds better and it's more compatible with opposing teeth.
So this is a separate lab.
This is a separate lab.
So you're using hot lab for anterior work.
Anterior work, correct.
And posterior work, you're using which lab?
Rocco's, Roccos.
Roccos.
Rocco's in Escondido, California.
And the www would be?
I think it's roccoslab.com. I can surely get back to you on that. Mm-hmm.
And is he Italian? Is he Italian and related to Rocky or Bullwinkle?
Well, I think he's Italian, but to be honest, it's the woman's lab, and her name is Christy Rocco, and she's fantastic.
Christy with a K or a C?
K with a K and an I at the end.
Okay, so for the first thing this dentist listened to is why do you have a separate lab for front teeth and anterior teeth and posterior work? Explain that decision first.
Well, there's a huge aesthetic difference in scrutiny in the front part of the mouth versus the back part of the mouth. Nobody's going to ask me for more translucency on a first molar. And so there's an economical difference. At HOP, the fee is going to be higher. At Rocco, the fee is going to be lower because there's a lower cosmetic value or artistic value in making that crown. And so that's why. And then with Christy, she's right here in town. I can get things in and back with her. We have a long-term relationship. She's not, she does anterior work, but when it needs to be AACD quality, I go to an AACD lab.
And so why is so first of all, to our young viewers, a lot of dentists are in denial. They don't want to hear that amalgams last longer than composites. You tell them that and they think you're speaking in fork tongue. But other ones don't want to hear that that when you file a tooth down, a molar down for a crown, a huge portion of them die and need a root canal within 10 years. Do you agree with that statement?
I try not to do a crown when I don't have to.
Right.
I agree with that statement.
It's extremely destructive. But you said that when you're doing an onlay, it's not all porcelain. You said it's porcelain and composite.
The material is a hybrid of porcelain and composite called diamond, and it's a lab out of New York. And I'm sorry I don't have that lab that makes that specialized material. And you can ask Christy Rocco exactly where she would get that.
So it's a.
But it's called diamond. It's not made out of diamonds, but it's called diamond onlay.
Diamond onlay, and that's the material. And is that like a stacked porcelain, or is that?
No, it's not. It's more like a composite than it is a porcelain, because I can take away from it and add to it if I'm missing a contact. I can sandblast it. I don't need to etch it. I just sandblast it and then place it that way.
Okay, do you care if I switch whole subject to a whole nother deal?
Not at all. And I got another topic I'd like to ask you about too. If you leave some time for that.
Absolutely. Okay, so what, there's so many dentists. I bet you 3,000 out of 4,000 listeners right now have never done an Invisalign case. What is that all about? Explain Invisalign. Do you think a dentist should learn Invisalign? Talk about Invisalign. How first of all, and how has your journey been with Invisalign? I mean, did you start this in 2002, or did you start it when you joined the AACD in 1998? Is Invisalign a big part of your practice? Is this something you just do once a year? Talk about Invisalign.
I started Invisalign about 6 years ago, but when I first got out of dental school, I was trained. I took a study club / continuum in orthodontics with fixed brackets and wires.
Who was that with?
Did a gentleman up in the Valley in LA, and I'd have to get you his name too. That's how bad I am with names. I apologize for that, Howard. But I learned how to do fixed orthodontics, and I did that for a while because the practice up in LA before I moved to San Diego was kids, and we do some orthodontics with kids. Then when I moved down to San Diego, I didn't see a lot of kids. Keeping brackets, keeping bands, keeping all the sizes made me crazy. So I put it off to the side. At that point, I got interested in the AACD and started doing cosmetic dentistry. And then 6 years ago, so what is that, 2008, 2009, an associate of mine started some Invisalign cases. And I thought it was interesting, but I was still busy doing my stuff. And then she left. So I had inherited these Invisalign cases. And then I started finishing them off and learning how to do it. And it became a new passion for me I'm more passionate about than cosmetic dentistry. Invisalign is cosmetic dentistry in the most minimally invasive way possible. And now I do fewer veneer cases because I offer the patients Invisalign first.
Exactly. And would you
agree? And
that
makes me feel so good, and I feel so bad sometimes about some of the teeth I ground down in the past. But it's just a learning process, and I have to let it go.
I know, and you treat other people like you want to be treated, and these dentists who would never, ever, ever file down their own daughter's teeth for veneers would tell their daughter, you're going to get braces and bleaching. But since they can't do braces, and they don't know how to do braces, they're filing everybody's teeth down. And if you file down 10 teeth for just 1.5 millimeters off for veneers, 10 years later, how many of those teeth died and needed a root canal? Or 20 years later?
Well, you definitely redo them at the very least.
Yeah.
But yes, I feel horrible about that, but that was my knowledge base, and nobody should feel bad, I don't think. But now my knowledge base is higher, and I have a much higher respect for natural tooth structure, and I have a way of solving it in a minimally invasive way. And so
how many Invisalign cases would you do for every veneer case? What's your ratio? Is it 1-to-1, 2-to-1, 3-to-1?
Do you know how many Invisalign cases I do a year, Howard?
How many?
I do 200.
Wow.
And I might do, 20 or 25 veneer cases that you would be significant for or more veneers.
So that's 10. So that's a 10-to-1 Invisalign over veneers.
Right. And
so what you're saying? What you're saying is the Invisalign market is 10 times bigger than the veneer market.
In my office, and I seek it out now.
Yeah.
Because it is such a good service. It makes people look better. They're healthier. Their teeth come together better. They're less damaging to themselves over their lifetime. There's nothing more fulfilling than finishing an Invisalign case and seeing someone smile, knowing that they have all their own tooth structure there.
Okay, you and I have been doing this for 30 years. So let's talk to these kids under 10. Do you think you can just go from no ortho to doing Invisalign or 6-month Power Procs or 6-month smiles? Or do you recommend, like you and I did, to do an ortho curriculum first? Like,
I think when we started, there was no way. I mean, it was like a closed club. I
Right.
mean, you're lucky if you
still
got an
is.
orthodontist to teach. I think now you can learn Invisalign and you can learn a lot. And I think now you can go to Six and Smile and you can learn a lot. There's a lot of places where you can learn it, but I think you need to study it on your own. You can't just read it in a book or buy it in a box. You have to work it out. But you can do ortho and you can do Invisalign.
But this kid's driving to work right now. What would be the first step? Would you recommend, like, what would be your first step? Give names. Well, how would you start your training if you've never done a class 1 ortho case, you've never done Invisalign, your school didn't teach it like most schools? What would be, we're on the first floor. We're going to go to the second floor where we're doing 200 Invisalign cases a year down the road. What would be the first step? How would you start this journey?
My prejudice is I'd have them go to an Invisalign intro course. They'd teach them how to use it. They'd teach them what cases to take, what cases not to take, have them do it on a staff member or family member, learn with, and then slowly move your skills up. There's a bunch of online stuff with Invisalign you can learn. There's a bunch of separate classes with Invisalign you can learn. You can go to some general dentistry or regular fixed orthodontic classes.
Now, you're a speaker for them, aren't you?
I am a speaker for Invisalign. Yes, I am.
Why don't you make an online intro class to Invisalign? Or it doesn't even have to be intro. It could be a 3-part series of beginning, middle. We put up 307 courses, and they've been viewed 500,000 times. A lot of these dentists, they say, well, I don't want to close down my office. I don't want to fly to California. Would you ever consider putting an Invisalign or an online CE course on Dental Town?
I'd be happy to, Howard, and I would give some people some general information. But on the Invisalign site, there is so much CE there. So I would tell people how to get into it and what to look for and how to operate their office, because I don't think Invisalign does that a lot.
So that's just Invisalign.com?
And then they can learn actually how to do it. If you become a providing doctor, there's all the CE you can possibly handle on there about class 1 cases, class 2 cases, molar uprighting, all that stuff is on there. Which is beautiful.
Invisalign.com.
Right. I tried to talk to doctors in San Diego and get them interested, and the information's all online, so it's kind of like redundant.
So
I'm a dentist.
How many courses are on Invisalign.com?
There's got to be 300.
Oh my God! So
about
300
about
courses.
an hour, half hour to an hour each. Mm-hmm.
So there's 300
all different topics.
And would it talk through diagnosing, treatment planning, class 1, class 2, class 3, the whole 9 yards?
Generally, yes, it would.
That is. And how much are those courses?
If you're a providing doctor, there's 0.
Okay. Well,
there's 0.
So,
and I'm surprised there's not more Invisalign on your site. I looked for a podcast like what we're doing here on Invisalign, and there wasn't even that subject.
Well, I don't know, but I have to guess this. Orthodontic company. Okay, so there's 9 specialties, right? The only one that didn't want to play on Dental Town, that wanted their own website, is OrthoTown. I never was asked by an endodontist, periodontist, pediatric dentist, oral surgeon. Everybody's on Dental Town. 200,000 members. The orthodontist, no. We're not going to play there with the GPs. We want our own site. And on their site, they don't, like on Dental Town, say you worked for Patterson or Shine or Dentrix or whatever. I didn't name it Dentist Town. I named it Dental Town because I couldn't be a good dentist if I didn't have about 500 dental companies making me stuff. I mean, I can't.
Exactly.
I don't have X-ray vision. I need an X-ray machine. I need materials. You need all these materials, and I want those on there because if I was Ultradent and everybody said your 00 cord needs to be blue instead of red, I think Ultradent needs to see that, and then I think we all need to work together. But the orthodontists, they don't even let their suppliers play. I mean. You could work for GAC or any of the ortho companies, Invisalign. It's only board certified orthodontists. And then the ortho supplying companies, if they start talking too much to GPs, the orthodontists get very, very upset. So there's 10,000 orthodontists, and they don't want to see their companies talking to GPs. So it's a.
I'm wondering if you'll find that with Invisalign or not, or if you found that with Invisalign, because they've been very open to me.
Let me put it this way. I don't even know who the CEO of Invisalign is. I don't even know what city they're at. I have 0.00 relationship with Invisalign. I didn't even know they had 300 courses on their deal. So it's kind of a touchy, taboo area when you're selling to orthodontists, and there's 10,000 of them. And they do a lot more ortho than the 120,000 GPs.
Well, you know? I think with Invisalign that story might be changing.
Huh. Well, do you know the owner of Invisalign?
I know the vice presidents, and I'll have them call you or have them call John.
Yeah.
So,
Tell me, what city are they out of?
They're up in Santa Clara.
Yeah, I feel sorry for them because it's tough when 10,000 people buy 80% of your business. And they get mad if you interfere with or talk to the other 120,000. I mean, I know ortho reps who have told me over the years, this orthodontist bought this many brackets a month. He was one of my best clients, and he found out I was selling like 2 sets of brackets to a GP across the street, and now he won't even answer my phone call or return my deal. So it's tough.
It was like implants, so that will break down.
So what you just said was very, very profound. You and I agree that when and what I can't stand about a lot of the lecture circuit people is, when you say, well, if you prepare, remember back in the 80s, you'd say, well, I did the composite just like you said, and the tooth was sensitive. Oh, it was you, Howard. You didn't use a rubber dam. I did. You overdried it. No, I didn't. You did something wrong, and it took 10 years before the Japanese said, yeah, it is their bonding agent. You guys all have sensitivity, and it's not because these speakers would write these articles like the top 10 reasons to avoid sensitivity. It's like, no, dude. The reason is the product I use. And the Japanese listened to that, and they came out with Clearfill SC, and they got rid of sensitivity. They showed that if your chairside chemistry set was designed better, you could get rid of a lot of this stuff. And a lot of these cosmetic people will not admit that if you do 100 posterior crowns on a molar, Gordon Christian said half of them will need a root canal in 7 years. If you prepare 10 teeth for veneers, in 10 years, 20% of those teeth will need endo. And you just said something profound. You're saying that even though you're a fellowship in the AACD, you do 10 Invisalign cases for every veneer cases. And it's minimally invasive. It's the only thing I would want for my 4 boys or my granddaughter would be braces and whitening, not filing down their teeth. And then you said something more profound, that you can learn Invisalign for free. You go to Invisalign.com, that there's literally 300 hours of online CE to learn that. That's just profound.
Correct. Now, let me talk about the AACD. The AACD is about minimally invasive, and they're getting that way. Of course, they're in the same route that I was in 2008, but now they're more minimally invasive, and they're talking about ortho more. So I want you to know that they want to do things and make people smile the best they can in the most minimally invasive way. And dentists are learning that there. They're not learning how to, as my friend said, smoke enamel. Hey, Dave, let's go out and smoke some enamel, Yeah. It's not about smoking enamel at the AACD. It's about doing it in the most minimally way possible.
Well, you've been given all kinds of great advice, and I don't want to let you go. I've only got you for 5 more minutes, but I got to jump on to... you use lasers too.
Correct.
What's that about? Talk about lasers.
I have a water lase and a biolase diode, and I use the water lase to do again minimally invasive dentistry. I do small to moderate size caries removal and fillings with my water lase. But I use my water lase, probably the most beneficial thing to me is doing closed flap crown lengthening in the anterior region, so that we can level gum lines and make our aesthetic cases even better, including ortho cases.
Okay, back up a little. Water lace. What type of laser is that?
It's biolase, water lace.
Water lace, biolase, but is that a diode, carbon dioxide?
It's an erbium. It's an erbium laser with water. Yeah.
Erbium laser with water, and you specifically do mostly soft tissue with that?
Small to medium-sized fillings.
Small to medium-sized hard tissue, enamel.
Correct. And then I do laser crown lengthening with it, 2 to 3 millimeters of laser crown lengthening in the anterior region to do closed flap crown lengthening rather than surgical crown lengthening. That way I could do the laser crown lengthening, prep the veneer, make the temporary. Patient comes back 2 or 3 weeks later for their veneer, and their tissue is healed, and it's healed at the same level that which I left it. And so it's very minimally invasive.
But would you say to do fellowship, academy, cosmetic dentistry quality work, not only are you going to have to use an outside aesthetic lab as opposed to in-house milling, but would you also say you're going to need a laser?
You'll need at least a diode laser to either that, or you have to pass on some cases where you can't change the level of the tissue, and you might have to refer it out and then have it back.
Okay, so you're saying that you would need a laser for some of these cases,
Correct.
And
a diode laser at least.
And there's a big difference in price because like AMD has a diode laser, and that's pretty. What is that like? It's under $3,000.
Yeah, 3 to 10,000 on a diode laser, but the water laser is 70, 60. I don't know what the newer ones
that's
are.
what I'm keying in on.
And
So
I wouldn't jump into that unless you are established and you know you want to do a lot of tissue recontouring.
So you would say that if you're just entering into it, you'd get a $3,000 laser. You said 3 to 10. What's the 3 to 10? 3 would be the AMD Allen Miller
and then
diode
I
laser.
think,
What would be the 10?
And again, don't quote me on these prices or get the companies in trouble, but I'm thinking somebody like Cavo or ADEC might have a $10,000 diode laser that might have some other frill that it does with it.
But the
anyways,
water
you only
lace.
need to spend 3 to 5,000, and you're fine with
Okay,
that.
but the water lace BioLace, the water lace BioLace, that's not a diode laser. That's a erbium laser.
Erbium laser.
And explain to these guys what's the difference between a diode laser and an erbium laser.
There are two different wavelengths, and so the diode cuts on red tissue, which is gum and blood. The erbium cuts on hard tissue like enamel and dentin, and so you need a stronger, along with water, in order to be able to cut that and cut it comfortably.
And could you do an occlusal with the water lace BioLace?
Sure, you sure can. Small to medium size occlusals, smaller interproximal caries.
So, and do you do many
without a shot?
Without a shot. And
Correct.
and on your work day, what are you? 4 days a week, Monday through Thursday?
I'm working. It's busy, Howard. I'm working 5 days a week.
And how many of those days, Monday through Friday, how many days a week would you pull out your water lace?
I probably pull it out twice a day.
Wow.
Either with tissue or with cavities. And if someone comes in and we do their cavities without giving them a shot and in a minimally invasive way, people love that without going out with a fat lip.
And again, I'm trying to, of the people who have their fellowship in the Academy of Cosmetic Dentistry, what percent of them do you think have the expensive $75,000 water lace BioLace?
Maybe 10%, maybe 7%.
So under 10%. So the other 90% can do it with just a low cost diode laser.
They can do some cases with low cost diode lasers. When you're taking more than 2 millimeters of tissue away, you start invading the biologic width, and that's where the water lace comes in, because you can actually remove bone and replace where the biologic width is.
And is that, would you say that's the hardest thing in cosmetic dentistry is when a woman comes in with a very gummy smile and she's got a high lip line? Men are 27% more muscle mass. When every photo I see of me, I don't even see any teeth. But you have some beautiful woman, and when she
Right.
smiles, it looks like her liver shows. What are you doing with those?
Those, if you need to do tissue and it's more than 3 millimeters, I would refer it to a periodontist to do that kind of work.
Do you ever refer them for orthodontic surgery to reposition that, or do you just think that's too extreme?
I'd talk to them about it, and then they'd kind of decide whether it was extreme or not. But I wouldn't be afraid to refer them for that, because I surely couldn't help them, and if I tried to, they'd be disappointed at the end.
And do you deal with cases like that very often? Is that a common case, or is that a pretty rare case?
A high lip line that can't be treated maybe 5 times a year.
A high lip line that can't be treated.
Can't be treated with either tissue and veneers. And it's an orthodontic case. It's probably 4 or 5 a year.
And Doc, I want to ask you one question. One rule of thumb I have is I ask patients after they've done it, would you do it again? Mm-hmm. And a lot of my patients who got facelifts or tummy tucks, and a lot of them say they would do it again. Some say they wouldn't do it again. On your experience, orthodontic surgery, that's extreme. In your entire 30-year career, how many of your orthodontic patients or just people you know or you refer to whatever would do it again?
I've never asked them that, but I know people aren't very anxious to do it, period. And so a lot of people compromise their orthodontics in order to avoid it. And so I don't blame them. I don't blame them.
I find that an extremely weird procedure because in the 30 years I've been out, from 87 on, almost all the oral surgeons who used to do it got out of it. So now they're just letting a couple guys do them all. And I would say this, all my male patients that had it done, not one of them would do it again. They said that was just the worst decision. And only women value that much pain and suffering to look a little bit better.
To look better.
But not one guy. I've
Well,
never had it.
You're very smart. I didn't ask my patients that, and that's a very good question to ask them, not only for that procedure or any other procedure we do.
Yeah. So I think guys are willing to pay a lot less pain and suffering for beauty, than
Howard, I know we're getting close to the end, but let me ask you one question. I'm sorry I'm turning the table. But, I'm concerned about PPO dentistry and what it's doing. As you know, we talked about high-end dentistry and then clinic dentistry. And my understanding, it's kind of hourglass shaped, where there's going to be the people that are on the high end, the boutique kind of practice, and then there's going to be the people that are in the clinics. And I don't know if dentists really know what's happening with them when they accept PPOs, but they're accepting a fee. And that fee schedule is not going up. And it's forcing them to do things like always add a buildup onto a crown, or maybe doing a two-surface filling instead of a one surface. And I'm not saying everybody does that, but that's the tendency. You're doing things that the insurance is going to pay for, and not doing the things that sometimes the patient only needs. And so Bill Dickerson explained this to me a long time ago, and I just saw him up at AACD. It's kind of like you're boiling frogs. And if you put frogs in the water when it's just regular temperature, they're happy, they swim around, you can turn the water up and it'll start boiling and none of them will drop out. But if you drop one in there and the water is already hot, they jump right out. Well, I feel like insurance companies are boiling dentists with not allowing fees to go up and squeezing them at every point. And so a dentist has to do more crowns, more fillings, more patients, and sacrifice quality care because of that. And that word needs to get out to people in dentistry so that people can make the choice rather than it just happening to them while they're being cooked in this water. And so I bring it to you and let you think about it and whether that's anything worth talking about, but I'd love to see Dental Talk debate that.
Well, that was an excellent close. We are out of time, and I want to tell you that seriously, that was a good sermon from the Mount. And I want to tell you seriously, thank you so much for spending an hour with me today. Take an hour.
Welcome.
I mean, you're working 5 days a week. You're a very busy man, and to spend a Friday afternoon with me for an hour for the benefit of all these podcast listeners. Thank you so much. I had an amazing time.
My pleasure. Thank you for including me, Howard. Keep doing what you're doing. Thank you.
All right. Take care, buddy. Bye-bye.
You too. Bye-bye.